webinar this morning. My name is Neil Davis. I'm a community pediatrician and work on sort of community population health issues and with the webinar. And this is definitely a very intriguing and important population health issue. I think we could certainly frame it that way. So just as a reminder, for questions, please enter those in the chat, and we love to get those questions. A couple other reminders, and Kylie can put this in the chat, but we have other educational opportunities through the virtual curbside podcast that Dr. Paul Workus does with the American Academy of Pediatrics, the Utah chapter. And I believe our guest today was recently on that podcast, which is another good resource. And then also the Department of Pediatrics at the University of Utah does pediatric echoes. I know they have one ongoing now related to autism, and there is another one starting soon about medically complex children and comprehensive care for them. So those are really good opportunities as well. I wanted to make sure to mention those. With those things said, let's go ahead and get started. And we welcome Dr. Doug Fair here today. As you can see, he's Associate Professor at the Division of Hematology Oncology, Department of Pediatrics at the University of Utah. And I also saw, I believe you're the co-director or medical director for the Adolescent and Young Adult Oncology Transition Program. Not exactly what that title is, Doug. Maybe you can tell us more about that. But some pretty critical work there as we think about what it means to have cancer survivorship and advance into adult medicine for the kids that experience cancer and its treatment. So with that said, Doug, thank you for joining us, and we'll turn this to you.
Oh, well, thank you so much for the introduction, Neil, and thank you so much for having me. And yes, I spoke on survivorship some months ago, and then I was also honored to be on Paul's podcast that talked about survivorship. And as mentioned, I work here at Primary Children's and Huntsman Cancer Institute and lead our solid tumor sarcoma program. But I'm going to talk today about Oncofertility, and I'll define what that is. If that's a new term to you, that's okay. And there's really some hats that I wear that somewhat overlap between AYA, which is adolescent and young adult cancer survivorship, and I serve a few roles there. So yeah, I'm really happy to be here, and thanks so much for having me. Let's see if I'm advancing here. Okay, no financial disclosures. So before I even go into the agenda for today, I just wanted to define oncofertility. It was only coined in 2006, which tells you that this is just a really pretty new and burgeoning field, and it's a combination of oncology and fertility. So the study of cancer, and in this case, the effects on cancer and fertility. So these are the learning objectives or agenda for today. It's to recognize the features of cancer and cancer therapy that can put patients at risk for infertility. And I also wanted to talk a bit about the various fertility preservation methods and alternatives currently available. What I won't go into today is really the pathophysiology that cytotoxic chemotherapy or chemotherapies and radiation have on the gonads, or the brain that then signals down to the gonads, just because it's a really deep topic. And I thought it might be more interesting and pertinent for this group just to kind of understand about what are the options out there for fertility preservation. But I appreciate that everyone who's joining on this morning and is wading a little bit into some esoteria here. So I also thought it'd be interesting to talk a little bit about the barriers to fertility preservation, some programmatic logistics, and actually costs. So we'll talk about the barriers to fertility preservation and really the access, and that is to a consult, to the medical therapies, the fertility preservation, and then again the cost barriers, and what we have done here locally. And really, I would say in some ways are in the vanguard and leading the nation, and I'll talk a little bit about that. So this is just a pictorial of how one can think about pediatric AYA cancer, and just to give some numbers to how many we're dealing with here. So when we say pediatric cancer, sometimes that means classic less than 18 years of age, but sometimes it also means less than 15, because adolescents and young adults with cancer is defined by the National Cancer Institute as 15 to 39 years of age. But if you combine those two groups, about 120,000 patients every year, less than 39 years of age, are diagnosed with cancer. And of course, that is the population, generally children, adolescents, young adults, that oncofertility is a real pertinent issue. Unfortunately, we are still using our three main methods to cure cancer, which is cut, poison, and burn. That is surgery, chemotherapy, and radiation. And while we're really proud of the successes we've made here in pediatric cancer, as you can see there, the survival rate is greater than 80%, depending on some data sources, are north of 85% now for pediatric and young adults with cancer. It's incredible, especially 40 years ago, is maybe just north of 40%. But that is still coming at a huge cost, because we're still using these very toxic methods. And I don't think we're getting away from these toxic methods really anytime soon. And so I think really our burden, and our burden to bear for oncology, is to really be focusing on these late effects and these things in survivorship, and fertility and family building and fertility preservation is one of those. And one of the most important that survivors have stated is the ability to build a family after they are done with cancer therapy. For those who have maybe seen this book, have heard of this book, it was a New York Times bestseller last year, came out about a year and a half ago. And the author there is Salika Jawad, and she's just a real hero. She was a young adult in her early 20s when she was diagnosed with cancer, and her memoir chronicles not only her journey through cancer therapy, but then also into survivorship, and really reflecting back on what it's like to be a young adult and be diagnosed and face cancer. And this is what this is a quote from one of the early chapters in her book, and talking about infertility. And she says this: "As much as I appreciate the medical team's support, the absence of communication on something so important felt like a breach of trust early on in our patient-doctor relationship. While my medical team was intent on saving my life, preserving my chance to be a mother someday hadn't seemed to be on the radar. She was not treated that long ago, and she was treating at one of the leading cancer cancer institutions in the country." So there's a couple of heroes I'm going to highlight in this story, and some of this that I'll mention will make a little bit more sense with context a little later. But picture on the right there is Brooke Lee. She was also a young adult who was diagnosed with cancer. She was a native Utah, and actually, like Suleika, is a Ivy League grad. Brooke went to Harvard University. She came back to Utah, got married, and was engaged in graduate school when she was diagnosed with breast cancer, and was treated up at Huntsman Cancer Institute. And being diagnosed with breast cancer, the team up at Huntsman mentioned that you're at risk for infertility, and set up a consult to see Dr. Joseph Letourneau, who I'll introduce later. And she had heard that she's not going to have any fertility preservation insurance coverage. And this is a really big barrier, and one we'll talk more about. So the lengths at which Brooke went is not atypical, but also just super tragic. So Brooke was diagnosed with breast cancer. She hears that she needs to start therapy sometime soon, and is at risk for infertility, and that she won't be able to pay for it. So she even goes to the lengths of applying for a job at Starbucks to try to get, because she heard that there is fertility preservation coverage as an employee at Starbucks. Luckily, in the midst of that, she met with Dr. Letourneau. Joe Letourneau had Brooke's husband, by coincidence, works in the IT department at the University of Utah, and very proud. And we'd worked for a few years with the University of Utah Insurance and some leaders up at Huntsman to advocate for this. But the University of Utah, in July of 2021, started providing fertility preservation coverage for for cancer patients. And this was a few months before Brooke had started. And because her husband worked at the University of Utah, she was able to get her fertility preservation covered. And so then she testified for us at a bill, and I'll talk a little bit more, House Bill 192, and this was to cover fertility preservation for Medicaid patients. And this is, Brooke gave such a moving and incredible testimony, but this is one quote from that. The most attention-grabbing consequence of chemotherapy for me is the lasting damage to reproductive organs and future fertility. University of Utah's fertility preservation coverage was life-changing. So proud of Brooke and so thankful for her advocacy. This is another local story, and I'm going to talk a little bit about House Joint Resolution 8. Probably didn't think we were going to get into any politics today, and I apologize that we're wading into those waters, but there's an important part of this story. So Lauren Kimball, also a hero, she was a kindergarten teacher when she was diagnosed with Hodgkin's, and that's a picture of her with her husband. And she also was given the same information that she might be at risk for being sterile after therapy. She went and had a consult, and unfortunately, as a state employee, they did not have any insurance coverage for fertility preservation, which again is just tragic and unfair. Her and her husband, even though the University of Utah REI group defrays costs using a lot of different methods, and really perform the service at usually typically about half the price. Sadly, Lauren and her husband still couldn't afford a little north of $5,000 out of pocket. Fortunately for Lauren, and she says that she's fortunate but knows not everyone has this, her parents came through and could pay for that. So her parents helped pay for fertility preservation coverage. And this is a quote. So she testified at the State House this year on a bill that we have that was fortunately passed, that was to get fertility preservation coverage for state employees like Lauren, like our firefighters, our teachers, police officers. And she said, I am an adult and professional, and my husband and I couldn't afford fertility preservation. And she gave this incredibly moving testimony, and you can see the videos of them in the archives of the of the legislature. All right, so that is some case examples that we'll swing back to, but I wanted those touch on a few issues, but I wanted to again mention what I'm not going to talk about today, which is super interesting. And there's just a lot of science here, and it's a burgeoning field scientifically or medically, which is fertility medicine and specifically oncofertility, but we won't talk about the pathophysiology of gonadotoxicity because it's just pretty deep. But what I do want to talk about, and this is a pretty boring, banal looking chart here, but I think it kind of gives you a little sense of how we think about the risk of infertility. And as we say in medicine and certainly in oncology, the poison is in the dose. And this chart is from a review paper that kind of talks about and lays out with some experts with the best knowledge about where our risk sits. So not everyone is at risk for fertility, although about half of patients who are diagnosed with cancer and have treatment are going to be at risk for fertility, and some of them have varying amounts of risk for infertility. And on the left there, you can see some of our common culprits, the alkylator family of medicines, heavy metals, those are platins, carboplatin, cisplatin. And we also know just a lot of chemotherapy, regardless of what family of chemotherapy they belong into, can be sterilizing. So if you undergo a bone marrow transplant, we counsel and expect that the patient will unfortunately be sterile afterwards. Radiation is also very toxic to both the gonads, whether you're talking about the ovary or testes, or to the signaling from the HPA, the hypothalamus pituitary axis. So yeah, when we sit down and do a consult with a patient, we talk about what is their therapy and then what is their risk for infertility. And then we have the same sort of chart and options for males, and there's a little bit of difference. We do know that there's a little difference in that females, if you're prepubertal, there's something a little protective about being prepubertal and the gonads not being activated. However, it's not perfect protection, and we still, unfortunately, cause infertility in a lot of prepubescent females and males. Okay, not going to really go into the biologic, immunologic, and targeted agents, which is really the future of cancer therapy. But to say two real points that I usually bring up when I'm giving talks on this topic and dive into the risk is, one, we don't really know a lot about what this how this affects gonadal function and fertility. And I think it speaks to a larger issue and a challenge in studying oncofertility and fertility preservation is that the outcomes are, decades down the road from when we give a certain agent or a therapy or a regimen. And that's just a really hard outcome because it's so far down the road. And then there's all these other personal factors, personal choice, a partner's um, uh, fertility. And so it's a really it's a really interesting and challenging problem that we have in studying fertility preservation and really understanding what puts somebody at risk. But all to say is that we don't have any great data from human beings and the outcome of choice, which is live births. But we do think that a lot of these immunologic targeted therapies are probably cause less toxicity than our standard cytotoxic chemotherapy and radiation therapy. So I'm going to show you this graph, this sort of interactive graph, which I think kind of demonstrates kind of what we're up against when we're talking about infertility. And we'll talk about females here. So on the left side, number of follicles or egg, and on the x-axis, you see the age 10, 20, 30, 40. And then that line is the number of follicles or eggs. And as you can see, it just naturally goes down over the course of a female's life. And then the dotted horizontal lines, so the bottom one is to represent when somebody would go into menopause and no longer be fertile. And then the top dotted line, horizontal, is showing when someone would be able to be fertile. So in between those two lines. And so you see the slanted line cuts into in this graph around the age of maybe 14. This is when a female would be able to conceive or be pregnant. And then you can see at the bottom where they are going into menopause and they can't. So then we say that there's this reproductive window. So there's these normal, from the average female, maybe 14 to 35, 39, 40, where they are able to get pregnant. So when you give chemotherapy, so in this pictorial, the age of 18 is when this patient was diagnosed with cancer and started gonadotoxic therapy. Well, you can notice two things happen in the graph here. One is that there's just this big jump, this big decrease in the number of follicles, and that happens immediately after. The other thing that if you can appreciate is the slope of the line changes and it becomes a lot more steep. So those two factors really shorten and condense this reproductive window. And so that really means that we do have limited time and limited opportunity to preserve someone's fertility. And in fact, 1 in 5 women, if you take all comers, AYAs, will experience menopause immediately after chemotherapy. So they are sterile right after. And then even those who might regain some menstrual function and some gonadal function, 40 to 90% will experience menopause, and that means a 2 to 3-fold increase in infertility. And so it's the amount of therapy they get, what type of therapy, then the age at which they get this therapy that means a lot. And as I'm going to talk about in a minute, the fertility preservation options are different and a little bit more limited for prepubescent females and males, which also give us some challenges. But we'll talk about our options. So I am going to transition now and talk about, okay, so that is sort of thinking about the risk of infertility and talking about how many patients this is and how it really affects a lot. Now we're going to talk about what are the current available strategies for females and males. And again, I'm just really proud here at the University of Utah, we offer the latest in fertility preservation options, which is just really proud of. So the first two, embryo cryopreservation, oocyte egg cryopreservation, also known as embryo freezing or egg freezing, harvest and freezing. This is our first line options for post-pubescent females. Now, essentially, egg cryopreservation and embryo is the same technology, except instead of just harvesting the eggs, then they would combine them with a partner sperm right there at the time of collection, and then freeze those embryos. These are options only available to females that have started their menstrual cycle. So, teenagers, late teens into their 20s or 30s. This is not available for prepubescents. This caused a huge problem because we didn't used to have any options for patients who were prepubescent. And now, through some decades of research, we now have options such as the ovarian tissue cryopreservation. So in this case, instead of stimulating the ovary to produce eggs and harvest those eggs, this is, because that wouldn't be possible in a prepubescent, this is actually taking surgically a piece of the ovarian tissue, and I'll show a picture of this in a minute, and then freezing that, and I'll talk about what you would do with after that. The last bullet there, ovarian transposition, we do this as standard of care, certainly, and this is to move the ovaries surgically if they are going to be in the radiation field. So this is talking about, and this is a pictorial showing ovarian tissue, ovarian stimulation. So there's two parts of collecting eggs. One is to stimulate the ovaries. And this is because if you look at the picture on the right, on the top, there's immature oocytes, and then a natural cycle, that blue arrow then shows that one follicle is matured and is ready for impregnation. And then there's some degenerated eggs. Well, if we're going to go in and collect an egg, wouldn't it be great if we can go collect a bunch of eggs? And so this is where the stimulation comes in. It's about 2 to 2.5 weeks of injected hormones. There's about 4 different hormones that we use to stimulate the ovary to then get a lot of eggs to mature. And so, and you can see that in the bottom. In the bottom right, that is an ultrasound of looking at a bunch of mature eggs. And so ideally, we get in the teens, sometimes in the 20s of mature eggs for these patients. And the general ratio of harvested eggs, mature eggs to live birth is usually about a 5 to 1, meaning, so if we collect 20 eggs, we generally can say, okay, if all goes well, on average, that means maybe the opportunity for 4 live births. So that is the option, and this is the treatment of choice for a post-pubescent female. This is a picture on the right, is kind of showing about how that was showing stimulation. This is how you go and retrieve them. So the female would go under anesthesia, and a needle is placed through the vaginal canal, and then using ultrasound and REI, or reproductive endocrinology, and a fertility doctor will go and then see those, look at ultrasounds, and then carefully with a needle extract those, and then put them in a certain soup of healthy nutrients, and then go and start the cryopreservation or the freezing process. And we do that right here at the University of Utah REI. It's right here on campus near the Natural History Museum. So, okay, so then this is a pictorial on the right talking about this ovarian tissue cryopreservation, which is, we don't use all that often because it is a little more invasive. It's a little less successful, but this is the only option that we have for prepubescent females. So we unfortunately see patients, and there's a 4-year-old diagnosed with stage 4 neuroblastoma. The conversation we have with the family is that we are going to sterilize your son or daughter. But we do thankfully have some opportunities, some hope in doing this procedure. So on the right is showing of the pictorial is sort of showing some what I was talking about is in taking some harvested eggs or parts of the ovary. On the left is going to be more of what we were talking about, the ovarian tissue cryopreservation, where you actually take slices, or we say sometimes strips, of the ovary, and then you cryopreserve those. You say, well, what do you do with those after? It's super interesting. But the in vivo method is that actually when the patient, say if they were 30 years old and then wanted to try to build a family and were otherwise sterile, well, those strips would be thawed, put back into typically the pelvis, but it can be in other parts of the body, which is crazy. It can technically be put underneath the skin of the arm, and the hormones are going through the body, stimulate that ovarian tissue, and it sort of wakes up, and then it does its thing that it's supposed to do, which is cause a follicle to mature. So then those eggs would be harvested in kind of the same way that we were just talking about with harvesting mature eggs, and then they would do in vivo or in vitro fertilization, so IVF. We are working on technologies to be able to do this ex vivo or outside of the body, which would be really great in case there's malignant cells that are part of we worry about in the ovarian tissue. And there would also be some other advantages, but we've had the literature would say there's maybe over 500 live births that have now come from ovarian tissue cryopreservation, and it's just really exciting. And it gives these options for both prepubescent females and postpubescent females who are diagnosed with cancer and cannot wait those 2 to 3 weeks of stimulation and harvest where they have to start therapy immediately. So that ovarian tissue cryopreservation can be done really immediately. And I think one of the things that sometimes is just so challenging about this line of work is just the timeliness and just that these patients need services immediately with 24 to 48 hours. And so it's always sort of an urgent or an emergency to kind of get these consults and get plans in place with families. That's one of the challenges. Okay, so talking about males, based on their physiology and anatomy, it's a lot more straightforward. And for most that are post-pubescent, sperm banking is the way to go. There are options as far as testicular sperm extraction, which we do here. We call it a TESE, and that is for patients that either cannot ejaculate for some reason, either from nerve dysfunction, or there might be other reasons in which they have a testicular tumor, and we want to try to go around that. I will say then if you talk about, well, what do you do for prepubescent males? Because the testes are not making sperm until they go through puberty. So this is where we haven't had quite the same success as with females. I'm very proud that we do offer now. We have an open IRB and a study to take testicular tissue and then cryopreserve it like we do for the ovarian tissue. We have not, though, in humans had any live births from testicular tissue that's extracted and then making sperm cells from that. I'll show you a cute picture of a monkey where we've had success in rhesus monkeys. But this is something that I'm really proud to at least offer, because the truth is we are planning on using this tissue if we need a couple decades from now. This is such a burgeoning field, such an evolving field. We're really hopeful that when these patients might need this, that the technology to then use that testicular tissue and get that to produce sperm, so then we can create a live birth will be available. But really proud to offer that here. And this is, a little pictorial up top of just a very simplified TESE procedure that our pediatric urologists or our urologists help us with, and just an incredible part of the team. And then below is Grady, the graft-derived baby. And this is what I was mentioning, where they took a rhesus monkey, they took a piece of testicular tissue, and then sterilized that monkey, re-implanted that testicular tissue back onto the testes, and the testicular tissue kind of woke up, and then sperm was able to be extracted, combined with a female rhesus egg, and then we have Grady, a healthy young monkey. So we're really excited and hoping that we will be able to translate this to humans soon. Okay, so I'm going to pivot again and talk about the barriers to fertility preservation, because there really are a lot, and it's been a labor of love to try to, and a lot of problem solving to work through all of these. But it's something that all cancer programs across the country are really facing, and I really throw these kind of into 3 buckets. So the first is access to fertility preservation expertise, both surgical and preservation. And again, I'm just like super proud to work with an incredible team here. This program that it was formally founded in 2018. I now lead this with two other individuals, Dr. Joseph Letourneau and Dr. Krista Childress. Joe is an REI, so an infertility doctor for females, and then Dr. Childress is a PAG, a pediatric adolescent gynecologist, one of two that we have here, and just incredible colleagues and clinicians. So they help lead the program, but they are also experts in being able to either on Joe's side retrieve and stimulate ovaries, and then Dr. Childress has helped us with ovarian tissue cryopreservation, and just incredible teammates. On the male side, Dr. Jim Hotaling, Dr. Kelly Gross there in the middle, and Dr. Glenn Lau. Jim and Kelly are urologists and work with male infertility. And then Glenn is one of our pediatric urologists. That's our lead in pediatric urology here. I'll have to say, I have to mention that, all of this started for me when Jim Hotaling came and gave a lecture here when I was a fellow, and he gave this really interesting and inspiring talk about the advances in male infertility treatment. And I remember just being like so excited, and also realized like I don't think we're offering any of our patients this, and this is what really started this journey for me. And Jim's been an incredible mentor and a help throughout all of this, so really thank Jim. Dr. Zach Kastenberg, one of our surgeons in our oncology lead in surgery, has always just been so helpful and when things come up, and has helped lead this as well. And that's Ben Emery and Dr. Kai Aston, who work in the preservation in the lab. And again, these two individuals and their team is bent over backwards for our pediatric and young adult cancer patients, whether it's helping a young man collect their sperm on a weekend. They just have always been over backwards, and they also are offering just the latest in therapies in cryopreservation, and it's just incredible, and we're really lucky to have them. Second bucket is access to quality discussion. It used to be, Joe and I talked about just being on call 24/7 for the last like 7 years for the whole Mountain West, and we're happy to take those calls and help arrange things. But we're really thankful and proud that Primary Children's has helped us out a little bit in that we have two awesome navigators. This is Ashley Kresser and Casey Bozer on the right, and they don't just do oncofertility. They do some other navigation, but they help with some of these consults, and they just joined us about a year ago, and we're super excited about having them and help them on the team. And then I'm going to talk a little bit later about the access to procedures or costs. So on the left is Joyce Renecki. She is the director of the Alliance for Fertility Preservation, and this is a group that works nationally to help advocate for increasing insurance coverage for fertility preservation. And she's been an incredible teammate, and on those bills that we helped bring forward. She was just integral to that. And then Representative Ray Ward on the right there, he has been our champion where we've written bills and then he helps champion them. So he's been our bill sponsor for both House Bill 192 that brought access to Medicaid patients fertility preservation, and then also for House Joint Resolution that helps with state employees. And really thank Representative Ward, and should mention, and Ray is totally okay sharing this, and he has publicly in his testimony. So he had a son who was treated for Burkitt's lymphoma here at Primary Children's, and most Burkitt's is curable the first time around. Unfortunately, his son relapsed, and the therapy is quite intense for relapse Burkitt's therapy, and he underwent a transplant, and he's a long-term survivor now, and I'm actually thinking about a career in medicine, but unfortunately he's sterile. And so Ray Ward has talked about that and shared his testimony and how this has really affected him personally. So I've said the word access a few times, and I just can't emphasize it enough, because really some of these technologies, some of these medicines like egg harvest is something we've been really good at for some decades. And so why are all cancer patients like not getting this, and why at Primary Children's were they not getting this, and at Huntsman and all over the country? It's because it's a really tough nut to crack as far as getting all of the people in place, and have all the processes in place. And there's just some barriers, but access is so important. And I really like this quote from Dr. Niederhuber, who is a former director of the National Cancer Institute. And he said, access to healthcare will be a greater barrier, a greater determinant of cancer treatment failure than scientific advances. And I think what this comes down to is that, I see progress is, is as much about implementation as about invention. And in oncology, we love our inventions, and I do too. I sit on some steering committees with COG and help design trials that, hopefully bring better therapies and increase that cure rate from 85.1% to 100%. But the truth is, there's a lot of things that we still can do well, and that just need, where patients need access. And that's where part of the story is here. I just want to mention that, like, while our program, really proud to be in the vanguard and one of the best, I think, in the country, this really should be standard of care. And it's been stated for years now, from the National Comprehensive Cancer Network, for the American Society of Clinical Oncology, from COG. They all have statements and have had those sometimes for 10 to 15 years already, really saying that discussing potential infertility and fertility preservation options is the standard of care. But as I've mentioned, it's not so straightforward. Just wanted to provide you some data to really demonstrate, like, how important this issue is for patients, and also how we're really kind of maybe failing as a country. So, do patients want to discuss fertility preservation and their risk? Absolutely. Survivors wish to have biologically related children. They actually place an increased value on parenthood as a result of their cancer experience. Achieving parenthood after cancer therapy can restore a sense of normalcy. And then there's also data to suggest that the loss of fertility can be as difficult to face as cancer itself. And Lauren expressed that personally to me, and Brooke as well. And they talked about that in their testimony in front of our state legislature. So then, are we discussing fertility preservation? Well, not nearly enough. Healthcare providers, I will say, it's been something that the movement is afoot to increase the conversations and access to fertility preservation. However, where we are in 2023 is where communication around infertility risk assessment and fertility preservations are suboptimal, and up to half of patients from recent reports mentioned that they have not received adequate information and have unmet needs. I was asked to, Elephants and Tea is a magazine that is for adolescent young adults with cancer. It's this incredible periodical that really tells patient stories, and they often have themes and certain topics that they focus on for that month. And I was honored to be asked to provide a clinician experience of fertility preservation in the conversation. And then there was 5 other AYAs who had had different experiences with oncofertility and talked about their experiences. But I wrote for this periodical, and the title of the article was "We Aren't Having the Conversation with Patients Enough. We, the oncologists, aren't having the conversation about infertility enough." And the subtitle was "There's no excuse, but there are challenges." And so I listed out 5 real challenges as to why we're just at least not even having the conversation. Like, why, with that data I just showed you, why are over half of patients who are AYAs or pediatric with cancer are not having a quality conversation about their risk and then their options. And reasons 1, 2, and 3 were kind of awkwardness, bad timing, and tough age. The awkwardness being that, we're still humans talking about this, and we're oncologists. And while we're used to talking about all of the organ systems, talking about sex, talking about gonadal function, talking about future fertility is not something that we necessarily were trained in, and it's just a tough topic. When we talk about bad timing, I often have to sit down with a 14-year-old, a 12-year-old, an 18-year-old who, building a family, some have maybe thought that might be in the cards for them, or that's something they desire. A lot of them have, that's the furthest thing from their mind. So, and they were just diagnosed with cancer, and I have to ask them to think about what their future self might be interested in. And that's just really hard. So, and the bad timing is also really speaking to the fact that they're just diagnosed with cancer. And then again, because these therapies really have to be initiated ideally before we start therapy, it's a huge rush in getting these things going. 4, we aren't trained for this. I'm really proud. Dr. Letourneau and I got a grant from the University of Utah to design modules to provide oncofertility education for not just pediatric oncology trainees, but for RAI trainees, for radiation oncology trainees, for adult oncology trainees. So really excited, but there are not training programs out there for oncofertility, and I didn't have any going through our fellowship here, which is the experience of everyone. And then what about the logistics and costs? It's hard to talk about these, to go and talk with families about their risk, and then not really understand exactly, okay, so now we're going to take the next steps for fertility preservation. It takes a lot of coordination, and it's really timely, and it's tough. And if you don't have all those pieces in place, it really will decrease the amount of oncologists that want to sit down and talk about that with patients. So sadly, in my piece, I had to, the piece was for a wider audience, but I had to give some advice about how to advocate for themselves, which I won't go over here because I think proudly our patients here at Primary Children's and I'm at Huntsman, hopefully the Mountain West, don't have to advocate for themselves. Okay, so the cost. This is where there's a real inequity. Females, based on their physiology and anatomy, not only is it more of a challenge and a process, it's also a much more costly process. So as you can see, the oocyte cryopreservation, the embryo cryopreservation, usually north of $10,000, 12, 15. About half of that is these really expensive medicines, and half of this is the ultrasounds and then the retrieval process. And then there's an ongoing cost of about $300 per year to keep that cryopreserved. Ovarian tissue cryopreservation, you're talking about surgery and then the actual preserving of the tissue. Whereas you compare that to sperm banking for males, which is what we really obviously encourage for post-pubescent males, you're talking hundreds of dollars. I will say, though, sadly, as we know, the number one cause of bankruptcy in this country is medical costs. About 42% of all patients who are diagnosed with cancer will be out of their life savings, have no financial support at all after 2 years of being diagnosed with cancer. And these are adolescents and young adults with cancer. They have not established themselves financially. So any amount of cost is a big burden. And again, why this is not covered by insurance is something that, it really goes to that most fertility preservation is not covered by insurance. And then this just kind of got lumped into that. So we're really trying to change that and change this narrative. If we have to go through a testing procedure, just really expensive. There are these national groups that we partner with to defray the costs, as we did for like Lauren Kimball. And we can get it down to sometimes $5,000, $6,000, but there's certain criteria they have to meet, and no family should have to face that. And I've had patients who just cannot afford that, particularly for their young, for their daughters. I talked about the movement is afoot to sort of change this. This is a map on the right of where we are with different states trying to, as we did here, pass some legislation. I'm really proud of Utah because we are really leading in passing 2 laws successfully. One is for Medicaid patients, they're most needy, which we were the first in the country. And then this also first in the country is for state employees, where the insurance that they cover. Some of the other states that have passed some will put some rules around some of the insurance providers in that state, but we've gone through a different strategy here, both covering the most needy, but then also going to the actual insurance coverage. So like I said, really proud that we worked with University of Utah. So now University of Utah employees have coverage. We've worked with Select Health. I'm so proud they've come to the table and wanted to get involved and provide fertility preservation for coverage for their employees through Select Health. So it's really exciting what we're doing here in Utah. This is just some sort of pictures of newspaper clippings talking about some of the challenges that we've had. So Ruby is over there on the left with the pink hair. She was an AYA cancer patient and talks about how she could not afford fertility preservation when she was diagnosed with cancer, and has been a real advocate for this issue and has been incredible. below is Lauren Kimball, who I mentioned. And then that's a picture of a Representative Ward there on the right. And so we're just super proud of House Bill 192 and House Joint Resolution 8, which not only are directly helping patients, but also helping other legislation in other states get passed. I wanted to mention, and apologies, this sound just really self-serving, but I wanted to mention that I was nominated and then received an award, the President's Award for this community cancer action this past year. And the reason I bring this up is because it was for the work in oncofertility. This award was not for AYAs. It wasn't geared towards pediatric cancer. It was all of cancer and all of issues of cancer. And to have won the President's Award, I think really speaks to how important oncofertility is, how much of a challenge it is to get programs going and to move the needle. And so it was really exciting to see oncofertility be recognized as such an important national issue for our patients. Just wanted to highlight a little bit of the sort of accomplishments. I graduated fellowship in 2016. I founded the University of Utah Primary Children's Oncofertility Program in 2018. And we're really excited about what we've done here, both clinically, programmatically, and academically. Maybe most important to me is on the left, clinically. So if you look at the patients, cancer patients who have undergone fertility preservation for the females in 2016, our REI group was about, and they serve all of the Mountain West. There are other REI groups, but most of the cancer patients who need fertility preservation go to the University of Utah. So it's a really good surrogate for how many across the Mountain West are getting this therapy. 2016, they had about 9 patients a year. To that last year, we had 80, actually a little over 80. For the male side, it used to be about 50. We're getting fertility preservation. Now, last year we had 248. And again, we now offer the latest in fertility preservation treatments, ovarian tissue cryopreservation, testicular tissue cryopreservation, giving hope to those prepubescent females and males. The consults now, we not only assure, and we have now for some years, that all the patients, 100% of patients, if you get diagnosed with cancer here at Primary Children's, you will understand your risk, and then you'll have a quality discussion, and we'll help fit whatever the desires for fertility preservation are. And we now, all of that is documented, and we audit ourselves and make sure that we are hitting that target of 100%. Programmatically, I already touched on some of them. It's just wonderful to work with such a team. Really, oncofertility is a real team sport. And as FDR said, I might not be the smartest fellow, but I can sure select some smart colleagues. And so I'm really just honored to work with some of the people that I've mentioned before. And it's really been a real fun thing. Besides passing the bills, I think we've done some fundraising. There's, along with that award that I won, there was a nice award prize of money that we're putting towards that's helping patients who can't afford fertility preservation. And I've worked with Walgreens and the foundation, and we're working on raising some additional funds for, again, those patients that are falling into the gap. And again, it is just it's a dichotomous at the end of the day when they say, I can't afford this or I can. And so we are helping, the goal being that no one would say no to fertility preservation just because of cost. And we've also been, I think, pretty busy academically, both in some basic science, some clinical science around oncofertility. And I think with that, I think I was going to leave a few minutes for questions, or if you have to hop off and get shoveling again, that would be understandable. So thank you so much for your attention. Thanks for all the support. There's a lot of people to thank, but Primaries, Intermountain, University of Utah have all been just really supportive of this effort and me. So thank you.
Great. Doug, thank you for that. That was super interesting and obviously really critical work. So much appreciated. It looks like Kylie's putting the CME code in the chat. Thank you, Kylie, for doing that. Questions, and if anybody has questions, please either come off mute. We are a small enough group here that would be just fine if you want to do that. Doug, I've got a question for you just about my own I was thinking I've got 4 patients in my community pediatric panel with cancer, and I think, lymphoma, a couple leukemias, and one with a Wilms tumor. And so, what's my role here? Now, these my own patients were pre-pubertal um, in those cases, but there are obviously those that are pubescent when they have their cancer. What is my role as a community pediatrician with these families? How can I interface and support this?
Yeah, thanks, Neil. I think it's a really good question, and we do a lot of consults for patients that have previously had their cancer therapy and meet with patients after. And what I would say is, I think the best step is actually um, whether they were treated here or not. I think we'd be happy to make them a survivorship care plan, and then within a survivorship care plan, um, which is again a tailored description of their therapy and the age in which they got it, and then part of that is um, an area that looks at their gonadotoxicity. And for some, like for instance, your Wilms tumor patient are probably at no risk. And that's the other thing that's really interesting about these fertility preservation consults. Families are so appreciative of even hearing that I'm at low risk or at no risk, just having that information. And then some of the other patients that you have might be at risk for infertility. And it's really important whether they preserve before or not to know that, because if that graph that I showed with that shortened reproductive window, they might be fertile now and be able to help preserve their future family building, but they might not be fertile at age 25 or 30 and might not know it. And there's some steps that we can take to um, do these things on the back end after therapy. So yeah, please reach out to us. We'll create a survivorship care plan. And then based on their risk, we'd be happy to see them and talk about the risk. And if the family is interested, we will certainly get the consult going.
Got it. So if I really focus in on, do you have a survivorship care plan? Do they know what that means? And have you discussed fertility with the team up at primaries? Those kind of questions, probably how I could support them the best and make sure they
Yep.
get connected.
Yep.
Okay.
Precisely.
Very helpful. Any other questions from the group? Okay. Well, thank you very much, Doug. Great discussion. Such great work. Thank you for bringing that to Utah. What an important thing. I'm so grateful for what you're doing. I hope you know that.
Oh, well, thanks, Neil. It's a real privilege. And so, yeah, I appreciate everybody's attention, especially this pretty esoteric topic. But yeah, I really appreciate all the support and the ability to present to you guys today.
Okay, great. Everyone have a great Wednesday. Thank you.